So take us through this 62-year-old male who started with drenching night sweats.
So this is a 62-year-old Hispanic male who presented with drenching night sweats and nausea and vomiting. And a few months later, workup revealed a right renal mass with bilateral lung metastasis. And a month later, he presented to our institution, and at the time, we had a clinical trial with sunitinib in patients who present with primary in situ and metastasis. And the eligibility criteria include doing a biopsy. So we did a biopsy of the right renal mass, and that confirmed clear cell histology. So we enrolled him on the pre-surgical sunitinib trial, and he had stable disease after one cycle, 50 milligram daily, 4 weeks on, 2 weeks off. And during the second cycle, which is the way the design of the trial was, during the second cycle, maintaining stability or response, patients would undergo then the cytoreductive nephrectomy. So he had the right radical nephrectomy and retroperitoneal lymph node dissection, recovered well from surgery, and post-operatively we resumed sunitinib at the standard dose and schedule. The pathology showed clear cell, Furman grade 3 with necrosis, lymphovascular invasion, and invasion into perinephric adipose tissue. 7 regional lymph nodes were negative for metastasis. He did well, however, had adverse events consisting of fatigue, nausea, vomiting, and hypertension, which led us to reduce the dose of sunitinib to 37.5 milligram, and we maintained him on the 4-week on, 2-week off schedule. The protocol did not call for altering the schedule, but reducing the dose. So that's what we did instead of what we would do now, which is the 2 weeks on, 1 week off, maintaining the full dose. He did well for about 3 years, and then progressed in his site of metastasis, the lungs, which is his dominant site of metastasis. And in March last year, we enrolled him on the phase 3 trial offered by Bristol, sponsored by Bristol Myers Squibb, of the PD-1 antibody nivolumab versus everolimus. He was randomized to everolimus, 10 milligram daily, and he received this agent from March through August 2013 and had disease progression in the lungs. And a month later, we started on axitinib, 5 milligram twice daily. And unfortunately, 4 months later, he has disease progression again in the lungs. However, he still has a good performance status of ECOG 1.
So I guess for the panel, this is kind of a classic case with multiple lines of therapy and very well managed, following high levels of evidence. But you kind of reach a point where the things available to the patient start to become diminished. I mean, one of the things that we're seeing in the practices is, and this is for you, Dan, should every patient get every drug that's commercially available for kidney cancer, or is there some point at which you should say these classes of drugs are not working and you have to move on to phase 1 trials, experimental therapeutics, and other options?
Yeah, so it's a great question. I'm not sure every patient needs every drug. I'm not sure we can get every patient to take every drug. But I think for the patients that maintain their performance status, that maintain tolerance to therapy, these are the patients that we want to keep treating. And, you know, in this case, you know, he's been on axitinib 5 milligrams twice a day for 4 months. You know, the question, you know, Brian might ask is, can you dose increase this patient? You know, could he tolerate a little bit higher dose? Even if he did have to take a little drug holiday for a couple of days, could he tolerate 7 milligrams BID? And would that make a difference? These drugs are not total clones of each other, and we have seen, at least anecdotally, responses to other VEGF TKIs, even though patients had progressed on one or more. So, you know, trying a drug like sorafenib or a drug like pazopanib off study, I think it is you know, really off label at this point. Still, I think it makes some sense for patients that have a good performance status. We certainly look towards phase 1 studies, other clinical trials for these patients when they're, again, sort of, you know, still eligible for those kinds of things. He's 62 years old, or he's 65 years old now. This is not the kind of patient we'd want to would want to just send to hospice if there are other things we can offer.
Yeah, but I often wonder, and this comes back to Brian's point, whether we are, we know that not all frontline patients get the second line, not all second line patients get the third line, and whether what's happening is we're self-selecting patients who predominantly have VEGF-dependent disease. And if they have predominantly VEGF-dependent disease, then a third or fourth line anti-VEGF target agent like sorafenib may make sense. I think what happens is we may be losing a lot of those patients in the earlier where their disease becomes other pathway dependent and VEGF doesn't control them.
No doubt, no doubt. And as someone that was on sunitinib for 22 months like this patient, clearly if he had that upfront, biology of, kind of other hypoxia-driven, growth factors and whatnot, it would have declared itself. I mean, the fact that he went that long on sunitinib tells me that he is one of these kind of chronic VEGF type patients. And so it makes sense to kind of go through and try to find either by dosing or by different drugs, another stabilization, effect with one of these agents. I don't think we can expect great partial responses in this setting, but stable disease in this setting can be very meaningful clinically.